Good evening, everyone. Today's Grand Rounds is on a case which was a diagnostic dilemma. I am Dr. Prerana Patil and that's, Dr. Madhangi will be presenting today's case. This session is being moderated by Dr. Varsha Backiavathy ma'am and Dr. Varsha Bhambhani ma'am. Moving on to the case, here we have a 5-year-old female who presented to us with multiple scalp ulcers since 2 years. The left eye showed proptosis since 1 year, which was gradually progressive since 1 month. She presented with swelling, pain, and diminution of vision since 2 days. Owing to the past history, since a very young age, she has been in and out of the hospital. At 7 months of age, she was diagnosed with TB lymphadenitis, for which she was treated with a full course of ATT. At 2 years of age, she developed impetigo on both lower limbs, for which oral antibiotics was given. At 2.5 years of age, she developed osteomyelitis and scalp ulcers started to show. At 3 years of age, she developed proptosis, for which she was given oral antibiotics and she was investigated further. Coming to a little bit of history, she was the second child to a non-consanguineous marriage. Antenatal and natal history was uneventful, but postnatally, she did develop respiratory distress syndrome for which she was hospitalized. She was immunized for her age and showed normal milestones. There was a significant history where her elder sibling died at the age of 3 months. They did not have any reports, so we were not sure what was the cause. Coming to the examination, we did a proptosis evaluation. Right eye was within normal limits, so I'll be discussing about the left eye. Best corrected visual acuity of the left eye. The patient could not follow light. Pupils could not be assessed, as we can see. The extraocular movements were restricted in all the gazes. We could not perform hurtles, hence worm's hole view, which showed gross proptosis. Retrobulbar retropulsion again could not be performed. Coming to the lid examination, she had a lag of thalamus of more than 10 mm. And on examination, we saw that the upper lid was tethered to the superior orbital rim. Coming to the anterior segment, the patient showed gross chemosis, complete corneal infiltrate, and exposure keratopathy. We'll be going in detail about the anterior segment by Dr. Madhangi. For now, the posterior segment, the right eye was within normal limits, and left eye we could not see the fundus, but on B scan there was a hypoechoic lesion which was noted superiorly in the orbit. Coming to systemic features, her respiratory system, CNS and cardiovascular system was all within normal limits, but the patient looked very frail and malnourished. She had multiple punched out lesions in the scalp, which shows rounded edges and active separation. She had a left ulnar lesion and a right tibial lesion as well. On orbit scans, this is a MRI orbit of the coronal section, which shows a lesion in the left superior temporal quadrant, which shows areas of necrosis. There shows osteolysis with altered bone marrow signals in the skull bones. The CT shows multiple lytic lesions and sclerosis both in the calvarium and in the orbital roof. We later went ahead and did a PET CT, which shows ill-defined lysis, mild enhancing tissues in frontal parietal bone. There was extracornal orbital involvement. The facial bones were involved, like right ramus, mandibles. There were lesions in the right tibia and the left ulna. She showed cervical lymphadenopathy. At this stage, we came up with a probable differential diagnosis. Can anyone try giving few differential diagnosis based on the history? Anything. You can even say it as based on proptosis, lag of thalamus, the CT findings, anything. With the most common, how did she present? She had redness, she had pain, she had swelling, proptosis. The patient was again subjected to a batteries of tests. The routine blood work was normal. She underwent bone marrow biopsy, scalp biopsy, tibial biopsy, and corneal scraping. Moving on to the biopsies, she underwent a CT guided biopsy of the right tibia, which showed just inflammation and areas of abscess and necrosis. The skin punch biopsy from the scalp just showed ulceration and again chronic inflammation. The bone marrow biopsy showed just reactive marrow with hemorrhages. Biopsy of the scalp lesion was negative for fungal, bacterial, and for CB-NAT, so which ruled out the reactivation of her previous TB. On corneal swab scraping, there again showed no growth. So All the tests were inconclusive. Again, blood culture showed no growth. The pus culture showed Staphylococcus aureus, which was not a definitive diagnosis for her condition. HIV was non-reactive, and Mount to this stage was non-reactive. Because of her systemic illness, she could not be further managed here and was referred to a higher center where she again underwent all these investigations.
So this particular patient was managed extremely well over there, which is why they had gone all out to diagnose as to what is happening. So now the GA was also a problem. So we had multiple sites from where we could take a biopsy. So the tibia, the scalp. So these were all could be done maybe under short GA and all that. So we tried everything, but everywhere, what was the result? Did you mention the reports of the
Yes, ma'am, everything was negative.
Yeah.
Those
So everything was, there was no particular diagnosis in this particular child. So it was just like a big dilemma as to what is the diagnosis? How do we treat this child? Right. So this particular child was also treated with a lot of IV antibiotics. Still nothing has been responded. It's been going on for years together. Right. Okay.
So for the interim period, they did a glue BCL, and the patient was then being planned for an orbital biopsy at SN. So later, on 14th September, she underwent incision biopsy, tarsorrhaphy, and a Gunderson's flap. Here, the first image shows the upper lid being tethered to the superior orbital rim. The second, on the further dissection, you see a lytic lesion here, the superior bone. And finally, she underwent tarsorrhaphy. This is a short video next showing the Gunderson.
Can you just go back to the previous slide? So here you can see that initially in the first picture when you saw, there was no lid only that you could visualize. So here you can see that actually the lid has gone and got stuck at the rim. So there is a full thickness defect in the lid. Okay. So when you have like the lid itself is not, there is a length of particular amount of lid that you have, right? The length, right? So it should be at least 20 millimeters usually. So now in this particular case, the lid itself is not there. So there is shortening of the lid. There is absence of tissue. Okay. So many times when there is severe absence of tissue, then you'll have to replace it with grafts, right? So, but in this particular patient, luckily when I had just all the tethered and areas, when I released it, I was able to do a tarsorrhaphy. Sometimes doing a tarsorrhaphy can be difficult in challenging situations because you do a tarsorrhaphy, it can gape again very easily. So you have to do a proper tarsorrhaphy. It's something that everyone needs to know from a general ophthalmology point of view because it can save the vision of the patient. Okay, so then this is what was done. Then what was done for the cornea part of it? Continue.
A Gunderson's flap was done. Next is a video showing how this technique is done.
So this particular video is from another patient. This is how it was done. A 360-degree peritomy was done and then it was sutured over the cornea completely. And then after that, a tarsorrhaphy was done. Dr. Varsha, would you like to add more on this?
So basically before you need to know that the cornea, the Gunderson flap, anything is going to attach on the cornea if the base is raw. So if it is epithelized, we really don't go ahead and do. So you first have to be very clear that it's an infection and it's not a scarred thing. You can use fluorescent strips intraoperatively also to see what are the areas of defect. Suppose a defect is only in the center 5 to 6 mm of the area. So that is the only area that is actually your Gunderson flap is going to go and attach, because if you are attaching something on a epithelized bed, it is just going to retract off. Okay, so as Dr. Varsha has done, because it was I think full corneal limbus to limbus thing, so you can take 2 flaps. Now what we need is that the flap that you are taking, it has to be a vascular pedicle. Okay, that's the reason that she has taken probably from both the sides. If you don't need to cover that much amount of area, if it's only like a particular half of the cornea, you can also take like only from one quadrant superiorly and just attach it onto that raw bed area with the inferior conjunctiva that is over that part. So the base has to be de-epithelized. It has to be raw, only then this flap is going to properly stick on that part. Okay, and it has to be thin. You do not actually need any kind of tenons that is going to come in with the flap, because what is the primary aim is to get an epithelial cover. You don't need to get the tenons along with the conjunctiva. It's only the conjunctival flap that we are interested in. Okay.
We sent again
May I
histopathological.
just add a little bit? Dr. Nivedita here.
Yes, ma'am. Please, ma'am.
Yeah, so very interesting class. Everything is going on very well. I just want to add, am I audible?
Yes, ma'am.
Yeah, so when it comes to Gunderson flap, we are that generation who used to routinely do Gunderson flap for corneal ulcers. So from that experience, we know that Gunderson flap is done for various reasons. Varsha had beautifully explained how a flap is done. That is typically done for a non-healing ulcer. And also when there is an ulcer which is thinning down and you are worried about perforation. So in those situations, you want a thin conjunctiva to cover up the area of infection, melt, thinning. Okay. So in this particular case, it is the proptosis which is very bothersome. And since the microbiological investigations have come out negative, it is not that ulcer which is the primary cause. The ulcer itself is the secondary cause due to exposure. If suppose we have had a clear cornea without infection, but the proptosis is so severe, we may still have to go and do a flap in order to get a complete closure of the cornea, so as to protect it from future complications. So sometimes you may be able to get a good flap. In these situations, it is better to cover the conjunctiva limbus to limbus. You have to wait for the proptosis to resolve, and as a secondary procedure, we'll have to open up and try for visual rehabilitation. That's all I want to add.
Thank you so much, ma'am. Thank you for your valuable inputs, ma'am. Yes. Can you continue?
We later sent these samples for histopathological examination. At multiple levels, the samples were taken not to miss any diagnosis, and all those samples came out negative. They just showed necrotic or suppurative lesion, again with chronic inflammation, which is again there was no conclusion or a definitive diagnosis even at this stage.
So at this point, you can see there's no tumor and there's no granuloma. It was just inflammatory tissue with necrosis, right? So where again the diagnosis was a big question mark, right?
Again, microbiological investigations, gram stain, KOH, calcofla, bacterial and fungal, again was non-conclusive. With this knowledge, because there was no particular diagnosis at SRMC, they went ahead and did a whole exon sequencing, which revealed there was a interferon growth factor, and then exon 6 was involved, which shows autosomal dominant type of immunodeficiency, which led to mycobacteriosis. And with this report, they went ahead and did repeat biopsies of the scalp, right cervical abscess and the left cervical node. Again, histopathology, AFB stain was negative, but MGIT culture, we'll be seeing about that later, which showed acid-fast bacilli growth in the culture. Gene expert was negative, but TB PCR for non-tubercular mycobacterium was positive and negative for mycobacterium tuberculosis. This is the histopathological slide showing caseous necrosis of the scalp lesion and the AFB stain, which is highlighted here. And this is the mycobacterium growth indicator broth, which shows a slender acid-fast bacilli. And this biopsy was from the scalp ulcer. This shows the real-time PCR for non-tubercular mycobacterium DNA. And then finally, to find out the species of this non-tubercular mycobacterium, they did a matrix-assisted laser desorption ionization time of light, which is a mass spectrometry technique. They used the fluid specimen to find out the species, and finally we found out that it was Mycobacterium chimera. I would now invite Dr. Madhangi to tell about the anterior segment findings before we move on to the discussion.
Thank you, Prerana. So, good evening, everyone. Today, I'll be discussing the cornea management which we have done for this patient. Myself, Dr. Madhangi. So, on the first visit, patient had severe proptosis, as we all know, and patient had severe conjunctival congestion and chemosis and near total corneal infiltrate. So, patient was diagnosed to have left eye corneal ulcer secondary to exposure keratopathy, and she was planned for blue BCL under general anesthesia. But the general anesthesia clearance was pending because of the systemic conditions, for which the patient was referred to SRMC. There, the patient underwent.
So, what is the most common causative organism you can think of if you have a corneal ulcer secondary to exposure? So, what are the causes generally for the corneal ulcers for first year PGs?
Not because of exposure, but because of neurotropic keratitis, we can consider viral causes.
Okay, but that is not the cause. I'm asking if the patient is having an exposure. So, first of all, basically, what are the different types of corneal ulcer causes? How will you broadly divide it? Organisms.
Bacterial causes, fungal causes, viral causes, and acanthamoeba
protozoans. Okay. So amongst these, what is the most common pathogen that you can suspect in a patient who is having such a history?
Because of since it's exposure, we can say because of skin infections. Is there any bacterial cause, bacterial keratitis?
So most common that we see in such kind of patients and with such short duration of history, usually it is bacterial causes that should come. With the picture can we go back to the So just describe the corneal ulcer part. Any one of you? If you want to describe PGs, first year or second years, how are you going to describe this photograph? If you have a corneal infiltrate, how will you describe that? Anyone? Size, depth, color, right? So this is almost a limbus to limbus near total corneal infiltrate, correct? We don't have a slit photograph. If you make a slit, you will be able to see what is the depth. If it's involving your full thickness of the cornea, or if it is superficial, if it is an anterior stromal thing. The child did not allow for a slit lamp examination because he was in a lot of pain. So we cannot really comment by this photograph on the depth of the infiltrate. Correct? What is the look of the infiltrate? Whitish, grayish, yellowish?
Whitish.
So it's mostly like a yellowish infiltrate. Correct? So you need to see what are the features when you are examining or when a photograph is given to you. So are there any satellite lesions? What is the extent? What is the depth? What is the color? Okay. Then how do you manage if the patient comes to you with this kind of picture? Then what is the next step that you would like to do? Scraping. Correct? So how do you scrape?
Yeah, come on, tell me.
We take a 15 number blade and we try to scrape it off from the...
So before 15 number blade putting in the cornea, what will you do?
Anesthesia.
Yeah. So you have to put proper anesthetic solutions. It's not that you put one drop and directly you take the blade and scrape, because cornea is very sensitive. The patient will not cooperate. So give proper anesthetic drops, then scrape, then you send. So what are in the scraping, what are the slides or what are the samples that you give? Anyone has seen cornea postings doing the scraping? Tell me. So initially we send it for grams, KOH. If you're suspecting any kind of tuberculosis or anything, then you ask for a special stain like ZN stain also. So depending on how many slides that you require, you might give samples in 3 or 4 slides. Okay. After that, we inoculate the culture part in the solid growth mediums. Okay. After that, we give it in the liquid broth medium also. And we give in a separate small vial if you want a PCR. So these basically your scraping material will be divided into these 4 categories. Okay. Then how will, if you have done the scraping, now the patient was had to be sent to the multi-speciality hospital for the further management. So you will just send off the patient like this. What will you do with such a bad corneal infiltrate that is there?
It's easy.
Yes. So why is the glue done? What is the benefits of using a glue for all such patients? How does glue work? And which glue would you like to use? So basically, if you speak about tissue adhesives, what are the two basic types of tissue adhesives that are used in ophthalmology? Synthetic and biological. Okay. So then we use cyanoacrylate glue for patients for corneal ulcers. So how does that glue work? What are the properties of the glue and what are the advantages of using that? So correct, very nice. So we use it as a patch, as an artificial tectonic patch in patients who have impending perforations. You can also use in such kind of patients, or you can use even if there is a small perforation. So how large a perforation you can glue it off? If the patient is having like a central 5 to 6 mm of a perforation, will you seal it off with the cyanoacrylate glue? But that is not the, if there's a pseudocornea, you will probably have to take up the patient for a therapeutic keratoplasty. Okay, if there is any kind of a delay, you can temporarily, because you want to give a tectonic support, you can put, but usually in that pseudocornea, that is where the glue might not stay. So you will have to keep seeing the patients every day. But I'm asking, there's no pseudocornea, there is a proper corneal infiltrate and a perforation. So you told me that for a 5 mm perforation, you're not going to put a glue. So for what size of the perforation, usually the glue PCL is done?
I'm fine. Like it.
So up to 2 to 3 mm of corneal perforation, you can use cyanoacrylate glue to seal. Usually more than that, we do some kind, we do other tectonic measures. Why not use glue for a 5 mm perforation? Why not use cyanoacrylate glue for a 5 mm perforation?
5 mm perforation is too big, ma'am, to support to a glue, ma'am. Also, the location matters, ma'am, for a 5 mm perforation. It could also lead to iris plugging as well as the anterior chamber flattening. So, till the time that we are awaiting therapeutic, we can do it for tectonic, but
In a 5 mm.
would be better. Well, small.
So you don't want the glue to have any contact with the intraocular structure because it's very toxic. So it can induce cataract, it can induce granulomatous uveitis also. So you don't want that glue to come in contact with the intraocular structures. The more big is the perforation, the chances of having complications like uveitis, cataract and other. So that's why we use it for 1 to 3 mm of perforations. Okay. After putting the glue, what do you do? Yeah. So can you put BCL in this patient? So then, is it okay if we don't put a BCL? Or is it compulsory to put a BCL over the glue? Why do we put a bandage contact lens? Yeah, tell me.
Because of the blinking process.
Correct. So we put a bandage contact lens because the cyanoacrylate glue has rough edges, and with each blink, it is going to cause trauma. This patient doesn't have any blink. Correct? So what was done, she is going to explain to you. We had the patient was sent to SRM hospital and there the scraping was done and just a glue was put because it was not possible to place a bandage contact lens with such a proptosed eye. And it is okay if you don't put it because there is no blink for this patient. Okay? Yeah, carry on, Madhangi.
So patient underwent glue in the left eye at SRM. Scraping showed no bacteria or fungus. Pus culture from the scalp lesion showed Staphylococcus aureus. Patient was started on topical fortified ceftazidime and topical tobramycin. So patient reviewed with us on 6th of September. Then the patient had staphylomatous contour with scarred infiltrate and loose glue. AC was appearing flat. Ultrasound of the left eye showed clear vitreous cavity, attached retina and hypoechoic lesion in the superior orbit. Patient was planned for left eye conjunctival hooding with permanent tarsography. So on 14th of September, patient underwent incisional biopsy of the orbital lesion along with conjunctival hooding and permanent tarsography. Intraoperatively, patient had a staphyloma with pseudocornea which was covered with Gunderson's flap. So postoperatively, patient reviewed with us on 1st of November when the patient had no infiltrate or epithelial defect. and the scarring was complete. So the discussion part will be continued by Dr. Prerana.
So with this diagnosis, we'll move ahead. The patient reviewed back to us at 1 month, and as told by Madhangi, this was her 1 month post-op, which shows there was no infiltration and just a corneal opacity with an intact tarsorrhaphy. After the diagnosis at SRMC, she was started at rifampicin, isoniazid, ethambutol, amikacin, and clarithromycin for a month, and this was her 1 month later with the healed scalp lesions.
Still healed.
Healing.
She is still under the treatment of ATTs. As you can see, the scalp lesions have already started to heal. Right? So it was a TB, case of TB. What type of TB was it?
Non-tubercular mycobacterium of Mycobacterium chimera species.
Right. With superadded other bacterial
Super
infection
infections.
also. Right? Yeah. Next, now we'll discuss about the...
Coming to the discussion, Mycobacterium chimera is a slow-growing non-tuberculous mycobacterium which belongs to the Mycobacterium avium complex. It was first seen a lot in following cardiac surgeries, and it was seen in immunocompromised patients, especially children with Mendelian susceptibility to Mycobacterium diseases. The immunity to this bacteria is by the interleukin 12 interferon gamma pathway, and in these children, MSMD often involves the defects in this pathway. Children with MSMD show non-tubercular mycobacterium, and they're susceptible to even BCG vaccine. The importance of improved diagnosis is because the conventional methods fail to treat or even identify these species.
Just 1 second, operator. So, can anyone tell me TB in the orbit? Generally, how does it present? What are the ways of presentation? Okay. In the orbit. Yes, TB can affect any part of the tissue in the eye actually, starting from the lids to sclera, episclera, everything. So, but in the orbit, what are the features? Very good. So, they can present as granuloma. What type of granuloma is it? Caseating necrosis with granules. So what are the other granulomatous lesions? Infective lesion, yes. So those are non-infective granulomatous lesions. What are other than TB? What is the other granulomatous inflammation? Infective. Usually we send this routinely. Fungus and TB. Fungus and TB both can cause granuloma, right? And there's non-infective granulomatous inflammation would be, common things would be sarcoidosis. That's not common, but yes. What other? Granulomatosis, polyangiitis. Okay, those are the common ones, right? So you should know a differential diagnosis for granulomatous inflammation. So that is one of the very common things. Then typically TB, how does it present in the orbit? Preta, can you take that question or...
Caseating necrosis, they have granulomatous.
Granuloma, yes. Other than that, the classical presentation?
Pulmonary tube.
What do they... Okay. Other than that, in other extrapulmonary, what do they have? How do they present?
Okay, lymph nodes.
Lymph nodes, yeah. Then, like a cold abscess, no? They'll definitely have it. So that also can happen. Then what else? Prerana, can you help about?
Posterior uveitis.
No, in the
Peripheral
orbit.
posterior
Yeah,
uveitis.
okay. In the orbit, classic periostitis. The bone involvement can be there, right? Osteomyelitis, osteolytic lesions. So there are 4 different ways of classical presentations of TB in the orbit. But this particular patient, apart from the fact that there were osteolytic lesions, but didn't have any other features, and also on biopsy there was no granuloma, no inflammation, and and the way the child presented was not like a typical case of a TB. So we were actually not thinking as a first diagnosis of TB when the child initially presented. That is because this is not the normal conventional TB which we usually see. This is a very rare form of TB which has affected this child. Why? It's a primary congenital immunodeficiency, which is a rare diagnosis, which, all right. So, but still this child had, diagnosing this child was a big task actually. So this is a important point to carry out, how we have to work as a team. As you can see here, though we can do the surgery and we can try to do all of this, we need inputs from our pediatrician or pediatric oncologist so that we diagnose the child properly. So, multi speciality involvement is mandatory. So, as you can see, this child has done quite well from where the child has started with, only because both orbit, cornea, and pediatricians are involved. So, this particular patient was managed for immunodeficiency and also for by an ID specialist and everything. You can carry.
Coming to the types, they who have complete and partial deficiencies, which based on its severity has total or partial loss of function. Isolated versus syndromic, where there can only be mycobacterial susceptibility or additional immunodeficiencies. If you remember, risk factors in these cases are BCG vaccination, exposure to environmental mycobacteria, recurrent infections with salmonella or fungal infections. BCG can be avoided in cases of family history or suspected cases of Mendelian susceptibility to mycobacterium disease cases. Coming to the clinical features, here you have severe recurrent or disseminated BCG infection, disseminated non-tuberculous mycobacterium infection. Again, you have sepsis, fever, lymphadenopathy. Again, lytic lesions are also seen. And I said before, recurrent salmonella and fungal infections are seen. Because NTMs are umbrella term, we have to find out each species present in various patterns. That's why these are they show poor response to standard treatment. Coming to the treatment, they are targeted antimycobacterial therapy with prolonged antibiotics of macrolides, rifampin, and ethambutol. Interferon gamma therapy is given, and in severe cases, we can even go for bone marrow transplant. Thank you. This was the end of the case.
So, I'd like to request, I think our pediatricians, if they're still online, they can add some inputs to this case.
Dr. Dharani here. So thank you for inviting us, and it's a very comprehensive presentation. In fact, it's overwhelming to see that they have gone up to the depth of partial defect, complete defect, and all that. So it's quite a comprehensive one. And you have highlighted the ordeal that we had to manage this child and multiple levels of investigations to get the diagnosis. In fact, the initial historical clues led us to the thought of primary immunodeficiency and doing a genetic sequencing after the initial screening was normal. And the genetic sequencing report, when we got it as a Mendelian susceptibility to mycobacterial disorder, it made us do our search more focused so that we get to the diagnosis of this NTM. So, and you rightly mentioned that it's a very comprehensive teamwork, and each and everyone involved is it's very important. No, if we actually miss even one person involved, then we probably might not have been able to manage the child so well like the way it has been done. So those have been highlighted. Coming to the initial diagnosis suspicion of LCH, when once that was ruled out, the chronicity which made us think of primary immunodeficiency has all been highlighted well. The tuberculosis, especially the osteoarticular tuberculosis, has been very challenging for us quite a long time. We had a skeletal tuberculosis earlier in a child with Fanconi anemia, who again was mimicking exactly malignancy. So a leukemia was the top differential for us. However, repeated biopsies, we could only get vague epithelioid granulomas. And the third time we got lucky in that child by getting, in fact, the culture positive. The gene expert was negative and the culture was positive. So, the fact that TB paucibacillary and getting it right in the immunocompromised patient is quite a rare thing. I think Dr. Divya, I'll let her highlight on that. The Mendelian susceptibility to mycobacterial disorder, as she rightly mentioned, the complete and partial defect. So this child, it definitely, based on the clinical scenario, has a complete defect. So there is no doubt about it. So those who have a complete defect have a very early onset, very disseminated infection and recurrent infection. They have the classical pterygoid and difficult to cure infections. So we haven't done any special functional assays in this child because it's not available straight away for us. However, the clinical picture is very much correlating with a complete defect. The biggest challenge for us is to cure the NTM here. And once we are there, we are not done until we get this child transplanted and have a good immune system. So we are working on that, and probably once the TB is under control, we may contemplate the process of transplant. I request the other team members if they have to add anything, and Dr. Divya to give her points. Thank you so much for inviting us.
Thank you, ma'am.
Thank you very much, ma'am. Thanks a lot.
Dr. Divya, ma'am?
Yeah, thanks for inviting me. So I'm Dr. Divya, currently working in Shamchandra Hospital. So the clues which made us think of an underlying immunodeficiency right from the beginning, like the presence of the BCG adenitis, and that too, which was very extensive, and it was treated with anti-tubercular therapy. So all that is a red flag sign in any child, like a big node not settling easily, and signs of dissemination, like if the child has an hepatosplenomegaly or pulmonary involvement. So I feel immunodeficiency workup needs to be done for these type of children at a very young age. And the second thing is the recurrent infections and non-healing scalp ulcers. So all these are pointing towards an underlying immunodeficiency. Once we got the diagnosis of MSMD, so we thought that these children are more prone to develop infection with less virulent bacteria. Like we all know, TB can cause these lytic lesions, but even BCG and this environmental, like the non-tubercular mycobacteria, can lead on to severe infections in these type of children, and they can be disseminated also. So even the initial set of investigations, they had sent everything, like expert cultures, everything was negative. One clue towards non-tubercular mycobacterial infection is usually it will be like expert negative, but the culture will pick it up. Expert can be positive in both BCG and TB, but is always negative in non-tuberculous mycobacteria. So second time when we had planned for the second line of investigations, we had coordinated with the microbiology team also. They were also informed about the procedures, and the samples were sent coordinated with the microbiology team. So once the sample was sent and the AFP was picked up in the smear, they had sent it for PCR, and the PCR initially identified it as non-tubercular mycobacteria. It is very essential to differentiate between TB and non-tubercular mycobacteria because the treatment varies. Usually in TB, we give HRZD, isoniazid, rifampicin, ethambutol, and pyrazinamide. Whereas in non-tubercular mycobacteria, rifampicin and ethambutol can be effective, but others like isoniazid and pyrazinamide usually don't work, and you will need other antimicrobials like either a macrolide or other group of antibiotics like clarithromycin, azithromycin, and fluoroquinolones like levofloxacin needs to be added. So that is why it is important to know what is the underlying organism. Is it like a tuberculous mycobacteria or a non-tuberculous mycobacteria? Even among the non-tuberculous mycobacteria, there are many different species. Like it can be fast growing or slow growing. Slow growing usually take more than 7 days for it to grow in the culture. And even among the slow growing mycobacteria, ours like Mycobacterium chimera is different. So you need to know the species also. At this point in time, MALDI-TOF helped to identify the species, and we were able to get the sensitivity also. So usually it will be a combination of antimycobacterial therapy, which will help to treat these kind of infections because they are more prone to develop resistance and they'll be refractory to treatment. So you have to give treatment for minimum of 1 year for such kind of disseminated and underlying bone involvement. So initially we started this child empirically, like once we got it as non-tuberculous mycobacteria, we started on 5-drug regimen like rifampicin, isoniazid, ethambutol, amikacin, and clarithromycin. But once we got the identification of the organism and the sensitivity, we narrowed it down like the 4-drug regimen, basically rifampicin, ethambutol, amikacin, and clarithromycin. So here also, like we have side effects of each drug. With amikacin, it needs to be given parenterally. So we had to put in an IV line, and so since it was planned for a longer duration, uh, a PIC line was inserted, and the oncology team had coordinated all those things so that treatment can go uninterrupted in this child. And so we'll have to monitor creatinine levels and also look for nephrotoxicity and ototoxicity while giving amikacin. And ethambutol already this has an hospital involvement. So how long to give ethambutol? So all these factors have to be taken into consideration. But after almost 1 to 2 months of therapy, the child had remarkably improved. Like the scalp lesions got better, less of discharge, and it's very dry. And we could also, see the difference very obviously in these type of children. So the main thing here is we will have to identify the underlying etiology. So to see the child as a whole, when put in the scalp ulcers, the hospital involvement, and the previous history of BCG adenitis, and underlying immunodeficiency was suspected. And after the immunodeficiency, the non-tuberculous mycobacteria was identified, and the species identification. All these help in treating this child, and in the final scenario, how she is like definitely a team management.
Ma'am, thank you very much for giving us so much of valuable inputs. Thank you, ma'am. So, anybody else want to add any comments? Dr. Envian, ma'am, or Dr. VGP, Dr. Mritika, Dr. Sharma?
Just for my curiosity,
Right.
what was the cause of proptosis? So much of proptosis, matlab,
So there is a mass, there is an extracorneal mass which was there, and also the lag of thymus itself is making it look like there's more proptosis than what there actually is. Yeah. So the other one more interesting thing, Prerana, can you tell me how will you manage the patient further?
Once the patient is systemically stable, we
Right.
can take up again for orbital biopsy and debulking of any
That will go away
posterior.
with the ATT treatment, no? Hopefully.
Ma'am, in
So
the
what will
tarsal,
we do further now?
we can see for more if the patient
Go
is.
back to that picture. Okay, it's all right. So there was a tarsorrhaphy. Like I mentioned, there's already a defect in the upper lid. The lid is not of sufficient length, right? So later on, might require some reconstructive procedure for the lid once the child is systemically all right. Because then I'm not sure whether for vision perspective, whether we can do some corneal procedures. In that case, they will require a good closure of the lid. So in that case, we'll require an oculoplasty reconstructive procedure followed by possibly can we do
we can do PK, but again, 5 years of child, we would like for now, if the plan from the pediatrician point of view is to systemically stabilize the patient, so that is what they should go ahead and do it. Till that point of time, probably just a globe salvage once the systemic status, the immunity comes, because in such patients, doing a keratoplasty, having secondary infections, the prognosis is not very good. Once the systemic things come in place, his immunity is better, and that point of time, how many years further it takes, because at 5 years, chances of him being amblyopic are also very high. So how much duration the treatment takes till that point of time? For now, it's a globe salvage, so probably close follow-up and covering like a prophylactic conjunctival flap permanent, so that he does not have a repeated epithelial breakdown in the cornea, which will be prone to the secondary infections because the complete blink is not there.
right.
Maybe the for now part.
Okay. Thank you. Thank you so much. So we tried to, cover an interesting case with a little bit of basic points, reach up to whatever is available, just for you to know these things are there and get interested in the subject. Okay. Any questions you guys have? All understood everything.
or nothing? Either they understood everything or nothing. Huh? Everything we understood. I would like to believe that. Huh?
Yeah.
Okay. If there's no further comments, can we end the class?
Thank you, everyone.
Thank you, Prerana, for taking the
you.
effort to put the PPT together. It was a confusing case to start with initially. Thank you, everyone, for joining.
Thank you, ma'am.
Okay. Thank you so much, in spite of it being quite late. Thank you so much.